This is Shahzad Ahmed presenting the fifth video in the series of ECG lectures. In this video, we will discuss about the abnormalities of the rhythm of the heart, which are called the arrhythmias. At the end of this video, I will also give you a stepwise approach for the diagnosis of arrhythmias. Before jumping on to the discussion of cardiac arrhythmias, we have to make you understand two important facts. Number one is that the cardiac conduction system as well as the cardiac myocytes have the property of automaticity, which means that every cell of the heart can generate a rhythm. And the second important fact is that each cell of the heart has its own intrinsic rate. So the arrhythmias are classified accordingly. We will be discussing the arrhythmias in the setting from which place they are originating. For example, if the rhythm is originating from sinus node, then it can be either sinus bradycardia or tachycardia. It can be sinus arrhythmia, sinus pause, or sinus block. If the rhythm is originating from atrium, then it can be either atrial fibrillation or flutter. It can be supraventricular tachycardia, atrial tachycardia, atrial ectopics, wandering atrial pacemaker, and multifocal atrial tachycardia. If the rhythm originates from AV node, then it can be either premature junctional contractions, junctional escape beats, accelerated junctional rhythm, or junctional tachycardia. If the rhythm originates from the ventricle, it can be ventricular premature contractions or escape beats, as well as accelerated idioventricular rhythm or ventricular tachycardia or fibrillation. We will be discussing these rhythms one by one. In sinus rhythm, each QRS complex is preceded by a normal P wave. The rate of this rhythm is usually 60 to 100 beats per minute. If the rate is less than 60, then it is called sinus bradycardia, and if the rate is more than 100 beats per minute, then it is called sinus tachycardia. Sinus arrhythmia is the exaggerated respiratory variations in heart rate. The ECG strip shown here depicts the sinus arrhythmia. Sinus pause is the condition where sinus node fails to discharge for a brief period of time. It is differentiated from its similar entity, which is called as sinus block or sinus exit block, by the fact that in sinus pause the interval between two R waves during the missed activity is not exact multiple of normal RR interval. The strip shown here depicts sinus pause. In case of sinus block, the interval between two R waves during the missed activity is exact multiple of normal RR interval. Here we have shown the ECG strip which depicts sinus exit block. You can see that during the missed activity, the total duration between two RR waves is exact multiple of the normal duration between two R waves. Wandering atrial pacemaker, the pacemaker shifts between SA node and other latent pacemakers. The ventricular rate in this type of rhythm is less than 100 beats per minute, and there are three or more distinct types of P waves visible. The strip shown here depicts wandering atrial pacemaker. You can see the varying morphology of P wave with every heartbeat, and the rate is less than 100. Multifocal atrial tachycardia is similar to wandering atrial pacemaker, but ventricular rate is more than 100 beats per minute. Here you can also see the varying P wave morphologies, but the rate is more than that seen in wandering atrial pacemaker. An atrial premature contraction is a narrow complex that occurs before the expected sinus beat. It is usually preceded by a P wave that has a different morphology from that of sinus P wave. or it may not have a P wave. In this ECG strip shown here, you can see an atrial premature complex at number 4. In atrial fibrillation, there is lack of organized atrial activity such that there is no P wave visible and there is irregular ventricular response. The strip shown here is of atrial fibrillation, in which there is no regular atrial activity depicted in the form of absence of P wave, as well as the ventricular complexes are irregular. In atrial flutter, there is organized atrial activity at a rate of 250 to 300 beats per minute, and there is variable degree of AV block, which can be 2:1, 3:1, or 4:1 or greater. The ECG strip shown here depicts the typical sawtooth waves seen in atrial flutter. In supraventricular tachycardia, the ventricular rate is so fast that atrial activity is not recognizable. Here you can see a strip which is depicting supraventricular tachycardia, most likely idioventricular nodal reentrant tachycardia. In junctional rhythm, there is absent inverted or a retrograde P wave. There are narrow QRS complexes, and the intrinsic rate of this rhythm is 40 to 60 beats per minute. A junctional escape beat is a junctional complex that comes after the expected sinus beat has missed. Here you can see the red arrow marks a junctional escape beat which is seen after the normal sinus beat has been missed. A junctional premature contraction is a junctional complex that occurs before the next expected sinus complex. Here you can see that the red arrows pointing towards the second as well as the second last complex indicate junctional premature contractions. We have already discussed that the rate of junctional rhythm is 40 to 60 beats per minute, and when the rate of this rhythm is between 60 to 100 beats per minute, it is called an accelerated junctional rhythm. And when the rate of this rhythm exceeds 100 beats per minute, it is termed as junctional tachycardia. In ventricular rhythm, there are absent normal relations of P waves with QRS complexes. The QRS complexes are wide, it is usually regular, and the rate is between 20 to 40 beats per minute. The strip shown here depicts ventricular rhythm. Premature ventricular contractions are the single ventricular beats that occur before the next expected sinus beat. These can occur in the form of couplets, triplets, bigeminy, trigeminy, or quadrigeminy. Shown here is a premature ventricular complex. The identification of this complex is that it is a broad complex. It is not preceded by a P wave. It comes before the next expected sinus beat, and it is different from the native QRS complexes, as well as the axis of QRS complex and the T wave in this complex is opposite to each other. In ventricular bigeminy, every alternate beat is a premature ventricular complex, which means that one sinus beat, then one premature ventricular complex, then sinus beat, then one PVC, and so on. In ventricular trigeminy, every third complex is a premature ventricular contraction. And in quadrigemini, every fourth complex is a ventricular premature contraction. Ventricular escape beats are the single ventricular complexes that occur after the expected sinus beat has missed. We have discussed that the rate of ventricular rhythm is between 20 to 40 beats per minute, and when this rate exceeds from 40 beats and is less than 100 beats per minute, it is called an accelerated idioventricular rhythm. Here you can see that there are no visible P waves. QRS complexes are broad, these are regular. The axis of QRS complex and T wave in each cycle is opposite to each other, and the rate is more than 40. So it is an accelerated idioventricular rhythm. When the rate of ventricular rhythm exceeds 120 beats per minute, it is called ventricular tachycardia. The rate can be between 120 to 250 beats per minute, and it can be monomorphic, polymorphic, or it can appear in the form of Torsades, T-points. The strip shown here depicts ventricular tachycardia, which is monomorphic. In ventricular fibrillation, there is chaotic electrical activity with no ventricular depolarization or contraction. Shown here is the morphology of ventricular fibrillation. In Torsades G-points, the QRS complexes or the electrical activity actually twists around a baseline, and shown here is the typical morphology of Torsades G-points. After discussion of all the arrhythmias, we come here to a stepwise approach toward the diagnosis of rhythm. In this approach, there is a 4-step algorithm. The first step is that you have to see whether the P wave is present or absent. If the P wave is absent, then it can be either atrial fibrillation or flutter. It can be supraventricular tachycardia, it can be a junctional or a ventricular rhythm. You can identify all these rhythms from the discussion already done in this video. And if the P wave is present, the second step in this algorithm will be to see the ratio of P waves to QRS complexes. If this ratio is not 1:1, then it is an atrioventricular block, a venodal block, and if this ratio is 1:1, then the third step in this rhythm analysis is to see whether RR interval is regular or not. If the RR interval is regular, then it is a sinus rhythm, and if RR interval is irregular, then the fourth step is to see the P wave morphology. If the P wave morphology is variable, then it is either a wandering atrial pacemaker or a multifocal atrial tachycardia. If the P wave morphology is same, then it can be either sinus arrhythmia, sinus pause, or a sinus exit block. So here we have completed the discussion on arrhythmias. Thank you very much.